I'm very pleased to be here at the plenary session. At the beginning, I'd like to just highlight the work of the ESDIP committee in putting this conference together year in, year out, and to thank our local hosts, David and Nasir, who've done an amazing job, I think, of pulling together this program in this really beautiful venue, and I hope it's going to be a really great few days. So it's my honor to introduce the second speaker at this plenary session, Professor Anant Madabhushi. He is a professor at Case Western Reserve University in the USA, and he also has the title of the Director of the Center for Computational Imaging, with an extra bit on the end that's really important, and Personalized Diagnostics. I think that job title sums up Anant's approach to research, that's about the computational work, the technical work, but applying that to real patient care and making an impact. He started as a biomedical engineer with a degree in Mumbai and did a PhD in biomedical engineering in the University of Pennsylvania. And he's been at Case Western since 2012. Those of you who have been in this community for a while will know Anant very well. He's a hugely productive individual. I note over 150 papers. That's probably out of date by now. He's got students on numerous projects, and he's always impressed me with his enormous community of students that he's got working with him at any one time. He's given hundreds of presentations, and he's got a very large portfolio of grants. And in fact, I'm a bit surprised that he's not writing a grant right now as I'm introducing him. Anant is a very valued member of our community, and that was recognized last year when he was made a fellow of the IEEE. Which is a very high honor. So I'd like to welcome him. Anant will be talking about computational pathology as a companion diagnostic, implications for precision medicine.
So thank you, Darren, for that very, very flattering introduction. Unfortunately, it's all going to be downhill from here on. So I want to thank Nasir and David for inviting me. I have to give a little bit of disclaimer up front before I begin. I got in at 1:30 this morning. And actually, interestingly, I just got back from a meeting in Australia on Saturday night. So I've actually been in 3 continents over the last 5 days. The reason I mention all of this is that any apparent lack of enthusiasm during the talk is not on account of that. It's just, you know, my body doesn't quite know what time it actually is right now, so it's my little bit of a disclaimer there. All right, so talking about disclaimers, like my good friend Mike Besage at the University of Pittsburgh says, no conflict, no interest. So thankfully, we actually do have some conflict of interest. I want to assure you and promise all of you that I am not going to be endorsing any products from any of these industry partners. What I cannot promise you, though, is my ability to not tell a Brexit joke during the course of this talk. All right, so let's dive into it. So I want to use cancer as an example or a use case. And the lifetime probability of a man, this is statistics centered around the United States, the lifetime probability of a man in the United States being diagnosed with some form of cancer is 1 in 2, so 50%. The likelihood of a woman in the United States being diagnosed with some form of cancer is 1 in 3. So if you look at it in totality, about 40% of the American population will be diagnosed with some form of cancer in their lifetime. So those are truly staggering statistics when you think about it. But it turns out when you actually look at the estimated number of deaths because of cancer, and these are slightly dated statistics from 2015, you notice that even though there's a large number of mortalities on account of cancer, something like 600,000 men and women dying because of cancer in 2015. There's a little bit of a disconnect between the actual incidence, the actual diagnosis of cancer, and the number of people who are actually dying on account of it, right? And so we've acknowledged that there are a few different reasons why this is happening. So clearly, one of the reasons why mortality on account of cancer is a little disconnected with the diagnostic incidence is because we're doing a much better job today at finding cancers early. We've got much better biomarkers. We are using imaging more aggressively to screen for a lot of these cancers. If we're finding a lot of them. We also have much better therapeutics today. I'll touch very, very briefly on immunotherapy, which of course is, I'm sure, all of you are aware, was the focus of the 2018 Nobel Prize in Medicine. And so immunotherapy has been a game changer. We've got much better therapeutics today that we're applying, and that is resulting in significantly more longevity for a lot of cancer patients. But perhaps in our attempt to treat a lot of these cancers, we are throwing the proverbial kitchen sink at a lot of these cancers. We are treating a lot of them more aggressively. Prostate cancer is a case in point where even though 1 in 6 men in the United States will be diagnosed with prostate cancer in his lifetime, only 1 in 40 will die on account of it. And so there are some real issues with regards to this so-called problem of overdiagnosis and overtreatment. There is a real issue that a lot of these cancers that perhaps should not be treated very aggressively are indeed being treated extremely aggressively. And there are 2 aspects to this. There is the aspect of toxicity, where you are essentially subjecting a lot of these patients to unnecessary radical therapy. In a lot of cases, you're subjecting patients to chemotherapy, for instance, where they may not really need or obtain added benefit of chemotherapy. But apart from the specific issue to the patient, the issue of toxicity, the issue of side effects on account of the more radical therapy, which may not necessarily be warranted, there is also the very real issue of financial toxicity. Right? So these are some statistics that have come out over the last few months. I think this was a paper in JAMA that suggested that 42% of new cancer patients lose their life savings. Right? These are staggering statistics. And this is particularly relevant given the large number of cancers being identified. Like I said, in the United States, 40% of the population will be identified with some form of cancer in their lifetime. But if 42% of these cancer patients are going to lose their life savings, then something is at fault here. There is a real fundamental issue, right? And the issue of financial toxicity, financial difficulty is really getting a lot more coverage. So as we've talked about treatment toxicity, the issue of financial toxicity is being recognized more and more as a real significant issue. Something like 60% of cancer patients may end up going completely bankrupt, right, on account of a cancer diagnosis. And so I really want to frame this conversation or frame this talk, yes, around artificial intelligence, yes, around the role of computational imaging. But while we think about the role of AI from a diagnostic perspective, there's a recognition more and more that we need to think about AI and pathology also from a prognostic and a predictive standpoint. And it's only in the last year or so that I've started to use this slide to really spell out, and this is really my education from my clinical colleagues and clinical mentors, that even though we think about diagnosis as being sort of the central problem that AI can address with trying to find disease early and diagnosis of disease, there are real issues with prognosticating what the outcome of disease might be. And yes, there's a lot of interest centered around identifying which patients might have disease progression, who is going to have metastasis. But perhaps even more than prognostic predictions is the ability to create what are called predictive analytics, so predictive companion diagnostics. And so from a clinician standpoint, from an oncologist standpoint, predictive diagnostics or predictive companion diagnostics are really critical because these allow for clinically actionable information on how to manage therapy for a given patient. Is this a patient who has perhaps less aggressive disease and therefore might not require adjuvant chemotherapy as an example? Or is this a patient who is going to respond to immunotherapy or not going to respond to immunotherapy? And so the use of the term predictive here is perhaps different from how a lot of us in the computational space, in the AI space, really think of prediction, right? So here predictive has a very, very specific meaning as it relates to the ability of a biomarker, as it relates to the ability of a classifier to be able to identify the benefit of therapy or the response to specific therapy. And it's really the ability to develop tools that address both the prognostic and the predictive questions that will really further our ability to really start to personalize therapeutic strategies for a given patient, as opposed to using sort of a one-size-fits-all strategy. Now, this is not to say that companion diagnostics have not been around. Classic example is Genomic Health's Oncotype DX, a 21 gene expression assay that has been around for over 20 years and has really transformed the landscape in which where early stage ER positive breast cancers are treated. Now, the status quo was that majority of these women who were identified with early stage ER positive breast cancer would get chemotherapy. They would get surgery, they get hormonal therapy, and then subsequently with adjuvant chemotherapy. But Oncotype DX came along, a 21 gene expression assay that now was able to identify which of these women, or so apparently 70% of these early stage ER positive breast cancers don't really require the adjuvant chemotherapy. A lot of them were getting treated very, very aggressively. Oncotype came along and essentially produced a risk score, so that if you had a high risk score, it reflected a need to get adjuvant chemotherapy because it reflected the fact that your disease was more aggressive. On the other hand, if you had a low risk score, it meant that you had less aggressive disease and therefore probably would not really benefit from the adjuvant chemotherapy. And so the assay essentially involved, or does involve, taking the tissue blocks, sampling it molecularly, and essentially coming up with these 21 different genes, and then there's an equation that essentially weights the individual gene groups and provides this risk score. And this really has been a game changer, right, for the management of these early stage ER positive breast cancers. But having said that, there is a recognition that a lot of these molecular-based companion diagnostic tests, be they genomic or proteomic, have an issue when it comes to intratumoral heterogeneity, because very often when you sample the tumor, you're sampling only a small part of it. And one of the things that we know about these tumors is that intratumoral heterogeneity is one of the hallmarks of the aggressiveness of the disease. The more morphologic and molecular heterogeneity there is, the likelihood that this is a more aggressive, worse prognostic tumor. This is a bad player. But when you're sampling the tissue for molecular assessment or looking at specific genes or proteins, if you're only sampling a small part of the tumor, there's a real issue that you may not be identifying or capturing the most aggressive component of the tumor, right? And more, there's a recognition that looking at morphologic heterogeneity or looking at features from routinely acquired data, such as a hematoxin eosin stain slide, there is a lot of information that one can get, but also that potentially by sampling multiple different slides from the tumor, you now have a better shot at really comprehensively characterizing and capturing the totality of the intratumoral morphologic heterogeneity in a way that one of these molecular diagnostic, molecular companion tests may not really be able to effectively do. And so what you're seeing here, and I'm sure there'll be several slides like this over the course of the 2 days, we can now digitize these slides fairly routinely. We can start to apply AI tools to go in and identify individual cells, individual primitives in the pathology slides. We can start to extract features from these various different primitives, just showing some of the work that we're doing in our group, where we're looking at the spatial architecture and the spatial arrangement of individual cells. Of course, a number of other folks in the audience are taking similar approaches. You can start to look at heterogeneity patterns within different tissue compartments, look at the stroma, look at the epithelium, and even down to the individual nuclear level. You can start to look at heterogeneity and texture patterns within individual nuclei to look at essentially the response of the chromatin arrangement within the individual nuclei. And so the beauty of all of this is that you can essentially convert digitally and non-destructively a routine hematoxin eosin slide into very, very rich quantitative information, or what is called a digital stain, that now basically provides a non-destructive digital biomarker that reflects the quantitative appearance of tumor morphology, and does this in a way that comprises of hundreds, potentially thousands of sub-visual measurements that really reflect what's happening in a very, very specific, quantitative, reproducible way, in a way that really is above and beyond the visual capabilities of the best a pathologist, right? And this is just simply not tenable because the number of measurements, the kind of subvisual measurements that you're getting really are much more than can be visually discerned simply by looking at the slide. And so this represents a real opportunity. Like Darren mentioned, I got my start at the University of Pennsylvania, and that's where, thanks to Dr. Mike Feldman and John Tomaszewski at Penn, I got my sort of first start into digital pathology. I started to look at applying computational tools back in the mid-2000s, looking at breast cancers and prostate cancers and trying to come up with ways in which we could look at automated identification of disease, automated grading of these cancers. Back in 2008 to 2009, I had the good fortune of meeting with Sridhar Ganesan, a breast oncologist at the Cancer Institute of New Jersey. And he was looking at some of the work we were doing in trying to automate the process of grading of breast and prostate cancers. And Sridhar came to me, and that's the first time I heard of this concept of prognostic and predictive medicine. And he said, well, you can do all of these things and provide grade measurements to the pathologist. But as an oncologist, as a clinician, to me, what is imperative is knowing how to treat the patient. And so therein, we started to really think about how we could look at digital pathology and AI, not solely from a diagnostic standpoint, but really asking the question, how can this benefit a clinician? Can we think of computational analysis of digital pathology as its own companion diagnostic? Can we think of this process of using AI with digital pathology to mine patterns and features that now just don't tell us about the presence of disease, or even the prognosis of the disease, but specifically, can we start to think of it as a way to predict added benefit of adjuvant chemotherapy? Can we identify, using this approach, which women are going to benefit from chemotherapy following surgery and which women are not? And so, analogous to the Oncotype risk score, we came up with the idea of the image-based risk score. And the idea was to essentially do AI based off digital pathology slides, which of course was nice because you were not disrupting the clinical workflow. You were taking standard hematoxin eosin stain slides from women who either had biopsies or surgical specimens. These were then being digitized with a whole slide scanner. With the application of the AI to the slides, we got a risk score, and that risk score now was an image-based risk score that could be used analogously to the Oncotype to basically identify which women might need the chemotherapy or which women might not. So that's the big picture story. The question is, well, how do you actually start to build something like this? How do you actually start to implement something like this? And this is a slide from actually work that I've done with Dr. Shu Jun, who's sitting over here, who's a professor at Nanjing University. And Shu Jun and I started to work together to think about fundamentally from a bottom-up process. If you think of fundamental building blocks of the image-based risk score, how do you go about creating a set of algorithms that can now prize out these measurements that ultimately enable a clinician to identify benefit of adjuvant chemotherapy? Well, the very first step was going in and identifying the individual cells, individual nuclei, because those were essentially the bedrock from which we were going to get the features, the digital biomarkers. You're going to hear a lot about deep learning over the course of the next 2 days, and that's fantastic. A few years ago, working with Shu Jun, we developed an approach using a stack sparse autoencoder to go in and find individual nuclei in these pathology images. I'm not going to sort of go into a full-blown tutorial on deep learning. You're going to hear a lot about this from several excellent talks over the course of the 2 days. But the use of neural networks has really been a very, very exciting and powerful addition to the armory, really, of computational pathology, right? So this has really been a game changer over the last 5 years. The ability to provide annotated images to the network and the ability of the network to then learn the target class really has provided ways in which now, in sort of a minimally interactive fashion, we can stand up networks to go in and identify targets of interest. And so that's what we found here, that by essentially providing a set of annotated images to the network, we could then go in and find nuclei very, very quickly, very, very rapidly. Andrew Janowick, who's also in the room, who I've had the pleasure of working with for about 10 years now, came out with this excellent paper a couple of years ago where Andrew essentially took deep learning and applied it across a number of different histologic primitives. So he showed in this paper that not only could you look at nuclei, but you could use it to go in and identify mitotic figures, you could identify tubules, you could identify lymphocytes, and also do tissue-level classification. So this was sort of one of the initial papers really demonstrating the breadth of the deep learning networks to go in and find a variety of different primitives very, very quickly. And of course, the sort of revolution continues, the transformation continues. This is a slide I borrowed from Shujun's student, Zerlin. And now with the use of generative adversarial networks with instance segmentation, we're actually able to get even better segmentation, really crisp segmentation of multiple different primitives in these hematoxin eosin stain slide images. And with these networks, with these approaches, you can not only just go in and segment the individual cells, but you can really very quickly identify different cell families as well. And so these different colors here really represent different cell families that the network is able to identify. And so I'm sure you're going to hear a lot about neural networks and deep learning, so I'm not going to sort of get into the minutiae with the specifics of the methodologies here. But I will briefly talk about an experiment that we published last year. Again, this was work led by Andrew and Jeff Nerschel, who was at that time at the University of Pennsylvania. And so I was working with some of the folks in cardiology at the University of Pennsylvania. And we had this idea, well, we've looked at deep learning to go in and identify individual primitives, different types of cells. But what could we do, or could we think about using deep learning to try to address higher level questions, specifically patient level classification? So yes, we've used it to go and identify specific targets of interest. We had previously published work where we showed that we could go in and find regions of invasive ductal carcinoma from whole slide images very, very quickly and accurately. But this was sort of a new sort of foray for us, because now we were saying, just given a set of slides, could we render patient-level diagnosis based off just that information at a whole slide level? And so we looked at what I will happily admit is a very contrived problem. We looked at a problem relating to endomyocardial biopsies from the University of Pennsylvania. And the question we were trying to address was, could we train the network to distinguish between patients who had heart failure based on the endomyocardial biopsies from patients who did not, right? And so we tried to do this fairly rigorously. We had a training set of patients, about 100 patients that we received from the University of Pennsylvania. And then we had another set of 105 patients that came from the same site, but were completely blinded to the training of the network. And so fundamentally what happened was we used the training studies to the network. We had labels essentially telling us whether these patients had heart failure or not. The network then went in and learned representations, and for sure all of you are aware, the neural network goes in and tries to find representations that may be non-intuitive, non-visual, but really provide the best possible separation between the targets of interest, between the classes of interest. So in this case, we were trying to find representations that could distinguish heart failure from non-heart failure from these endomyocardial biopsies. We did the training and then brought out the validation set of 105 patients and applied the network to that validation set. But we also wanted to make it interesting. So we got a couple of pathologists, cardiac pathologists, had them look at the validation set and said, well, could you look at these images and tell us whether there's heart failure or not? And so when we looked at the results on the validation set, I apologize if it's a little, the font's a little small there, but essentially we got a AUC, an area under the curve for the network of 0.97. And for the two pathologists, we got an average area under the curve of 0.74, right? And so this was exciting. We got the data, we put the paper out. I reached out to our marketing folks at the at Case Western Reserve University. I said, we've got some interesting data here. I think there's a real opportunity to put out a story that really talks about how AI, deep learning can complement the pathologist, right? Really serve as decision support for the pathologist, provide them a tool to really empower what they do. At least that was the intent I had with regard to the story when I spoke to my marketing folks. Of course, that's not how it turned out, because very quickly the story that really was sexier than the one I'd intended was, of course, computer beats doctor again, and G Reports picked it up as one of the 5 coolest things on earth. Subsequently, I was at a meeting at the NIH when one of my students wrote to me saying, hey, guess what, you're trending on Reddit. So the story went out. I wasn't aware what he was talking about until I logged down. Being a Twitter person myself, this was a new social media platform that I wasn't aware of. And sure enough, there was this picture of me, and then there was this story about how the machine had beat 2 pathologists, and there was a lot of buzz around it. A whole bunch of comments that were coming up with people who were following the story, and so this was very exciting. I actually went through some of these comments. I picked out one that I thought was really interesting. So I thought I'd share that with you. So apparently this whole AI computational pathology thing doesn't work out. I just actually might have a career in TV. So that's all well and good. But there's a backstory here. And the backstory is that after we put this paper out, we actually wrote back to the University of Pennsylvania and said, well, we've done one validation, let's do another validation. And so working with Ken Margelis and Mike Feldman at the University of Pennsylvania, we got another cohort of cases from the same institutions. Remember, this is the same lab, the same institution, the same demographics. We said, send us another blinded set of 90 or 100 patients, and let's see whether the network comes up again with that level of performance, that 0.97 AUC that we saw. And so, as it turns out, when we got that second validation set and applied the network, the AUC went from 0.97 down to 0.75. And so this was really staggering. This was really startling on account of a few different reasons. One was this was the same institution where we had trained the data. This is the same institution where we'd gotten our first validation set. And there couldn't really have been many changes, dramatic changes with the slide preparation. The pre-analytics were more or less the same, consistent. The scanner was the same, right? And the patient population was the same because it was coming again from Philadelphia and from the University of Pennsylvania. So this was really, really staggering. And then it was something that Andrew and Jeff sort of really tried to figure this out. They focused on this for several weeks. And the best that we could come up with in terms of an explanation was that somewhere along the way, between that first validation set and the second validation set, a remote software upgrade had been applied to the scanner, to the whole slide scanner. We went back and looked at the images, and even though the images looked more or less consistent to the pathologist, there possibly might have been some perturbation to the characteristics of the image that might have affected the network, and therefore the performance of the classifier in predicting heart failure. And so I want to be a little contrarian here and talk about some of the challenges of these approaches, right? And so we're hearing more and more about some of the potential pitfalls of these sort of deep learning strategies. This is a quote from Professor Jordan at the University of California, Berkeley. He talks about not really trusting these brute force algorithms. And when this story broke, I went online and came across this story, which maybe perhaps a number of you might be familiar with. This is work done by Samir Singh, an assistant professor of computer science at the University of California, Irvine. And Samir was looking at training neural networks to distinguish wolves from huskies, right? And so that's a tough problem because wolves and huskies look very similar to each other. And so he and a student trained up a network to go in and distinguish these two animals from each other. And when they applied it to an independent set of cases, they got a 99% accuracy. Now, thankfully, Samir realized that there was something that was off here. The network couldn't be doing that well because this is a difficult, challenging problem. Fortunately, they were actually able to come up with why the network was doing as well as it was. It was simply because huskies were invariably on some sort of white background. Right? So any image, or most of the images which had huskies in them, had snow in the background. Right? And so there was always something that was white in the background with respect to huskies' images. And so that's what the network was picking up. It wasn't actually picking up features of the face of the animal itself. It was picking up patterns off the background, and it recognized that in images of huskies versus wolves, there was invariably snow, or there was something that was different about the background. And so this, I think, it brings home the point that we really need to be careful. We need to be thinking about these approaches more critically, more systematically. And this is particularly relevant when you start to talk about high-stakes decisions, right? Excellent NPR story that broke, I think, a couple of days ago. Cynthia Rudin, who actually gave one of the keynote addresses at the NIPS meeting in Montreal last year, really talked about this, right? Talked about, black box models and this current craze to try to explain these black box models, particularly for high stakes decisions. I mean, she's very candid in her assessment, and this was said in her paper at the NIPS meeting, but she also stated this in the interview that came out on NPR a couple of days ago. Feel free to look that up. Really excellent article showing her perspective on these approaches. I think from sort of the precision medicine, precision diagnostic perspective, I think it's very important to bear in mind that when you're talking about making strategies, decisions on how patients should be treated, should these patients get chemotherapy, should they get immunotherapy, I think there's a real need to make sure that the approaches that we have, the models we have, are interpretable, right? And it can't just be that, well, you're going to decide whether or not to give a patient chemotherapy because the box said so, right? Or because a neural network strategy where representations might be somewhat more opaque, maybe less interpretable, because that's what it said, and that can't really be the basis of making some of these decisions, particularly when it comes to deciding on therapy. And so I want to be a little contrarian, and I want to talk about sort of the other class of approaches, what are called handcrafted features, that potentially could, in these high-stakes decisions or high-stakes problems, where you're trying to make decisions about prognosis or predictive medicine, could provide an intuitive alternative to sort of the neural network strategies. And so as I go through this, I want to make sure that I don't suggest that neural networks are bad, right? So I mean, we've certainly used neural networks. We continue to use them, and I think there's a huge opportunity here with the neural network strategies. But I do want to mention that when it comes to some of these particular tasks, these particular, like I said, high-level critical decisions, we may need to think about what's going on. And the ability to create classifiers where there is a way to go back and figure out, what went wrong, because inevitably something will go wrong. We've got to be able to figure out what that issue was, what that problem was, right? And it can't simply be that, well, we're going to address the problem by throwing more data at it, right? Because, we've all heard this, right? The neural network didn't work. Oh, that's okay. We just need 100,000 more cases, and then it'll work, right? So I want to talk over my next few slides about handcrafted features as sort of an intuitive alternative. I want to talk about something that has been accepted at the ASCO meeting that we'll be presenting in Chicago over the summer, where we've been looking at the role of collagen fibers. Now, there's a lot of interest and has been a lot of interest in imaging of collagen, and excellent work going on from Kevin Eliseri's group in Madison and Rich Levinson over in California, doing really, really great work in imaging of collagen. And so we have been looking at the role of collagen just from H&E images as potentially a prognostic biomarker for predicting outcome. And so one of the things we've been looking at is, could we look at trying to understand the orientation and the anisotropy of collagen fibers using AI from routine H&E images, and see whether there are differences in this orientation of the collagen fibers between patients who are short-term survivors versus long-term survivors. And so what we found is that there are significant differences in the degree of disorder of these collagen fibers between patients with different prognosis. And so this is work that's being done by Haojia Lee, a graduate student in my group. And what Haojia has shown is that if you look at the collagen fiber orientation in early stage breast cancers, the orientation and the order of these fibers are very, very different between patients who have short-term survival versus long-term survival. And so in this work that we hope to be presenting at the ASCO meeting, we've shown now in over 400 patients that just the orientation of these collagen fibers alone turns out to be a very strong prognostic marker of survival in early stage ER-positive breast cancers. But it's not just the collagen. I mean, there is other features as well that are relatively simple, but provide a great deal of prognostic capability. This is work from Dr. Lu Chung in our group. This was published in Lab Investigation a few months ago, where Chung essentially showed that looking just at the shape of individual nuclei and the orientation of individual nuclei, again, we could create prognostic predictors or prognostic classifiers that could distinguish short-term survivors from long-term survivors. What he found in this work was that if you looked at patients who had long-term survival and therefore better outcome, the orientation of the individual cells were more coherently organized compared to patients who had short-term survival, where the orientations of those individual cells were more chaotically arranged with respect to each other. And so what we were able to do was to convert that into a computational marker, and essentially used the notion of entropy with respect to the orientations of the cells to distinguish short-term survivors from long-term survivors. And so this is sort of my tongue-in-cheek comparison of the sort of oncotype and the IBRIS test, and you'll indulge me this one slide. But why I'm really excited about these kinds of approaches is because this could really have a significant global impact. Because you talk about the cost of these tests, the oncotype retails for something like $4,600 in the United States. Compare that with a test like IBRIS that only requires a digital H&E slide image. You're talking about log orders of magnitude lower cost compared to these molecular diagnostic tests. There's also the turnaround time, right? So with these molecular tests, you're talking about things that have to be shipped out to a specific facility, and then the test has to come back. And so that could take several weeks. With IBRIS, you could essentially be doing this in an order of minutes. The global footprint of these tests is another extremely enticing, exciting opportunity. And therefore, in other words, you've got an inexpensive, fast, reliable, accessible prognostic breast cancer test that's priceless. For everything else, there's Mastercard. Right? Just a few other cases, a few other examples. One of the things that gets talked about very often is validation of these approaches. And so we've been very, very fortunate working with the Eastern Cooperative Oncology Group to actually get access to their clinical trial data set, 2197, which is a multi-site randomized clinical trial involving ER-positive breast cancer patients. And so working with them over the course of 2 years, we got access to the slides, we digitized the slides, and actually showed that the IBRIS test, using just 2 features when complemented with the oncotype test, was able to significantly improve on the accuracy of oncotype. In other words, we were actually able to show that we could identify 20% more truly low-risk breast cancers, identify 20% more patients who could avoid adjuvant chemotherapy compared to just the oncotype DX test alone. But this idea of the image-based risk score we found really applies across the board to a number of other cancers as well. This is work we're doing in early stage lung cancers, where again, it's a very, very similar issue. Which of these patients requires chemotherapy following surgery, which of these patients don't? And we're finding that these patterns relating to nuclear appearance are strongly prognostic of survival in early stage squamous cell carcinomas, and also in early stage lung adenocarcinomas, these features hold up. They're strongly prognostic, and we've getting ready to submit this paper for possible publication. In separate work that we recently published in Clinical Cancer Research, we've been focused on the role of tumor infiltrating lymphocytes. Obviously, there's a lot of interest right now on tumor infiltrating lymphocytes, particularly in this age of checkpoint inhibitors. And so in this paper that we just recently published in Clinical Cancer Research, in fact, it came out last month, we showed that the spatial arrangement on the interaction of TILs with respect to cancer nuclei was strongly prognostic of recurrence in early stage lung cancer. So it was interesting that we found that in non-recurrence patients, patients who had better prognosis, you see these dominant TIL clusters, the clusters in green surrounding the cancer nuclear cluster, and essentially providing sort of a mothering or an enveloping effect around the cancer nuclear cluster. But in the patients who did have recurrence, you didn't really see that particular signature or that particular configuration. You saw that the cancer nuclear clusters were larger, the TIL clusters were smaller and more fragmented, not really providing that sort of enveloping effect. We've actually now shown that this sort of spatial interplay between TILs and cancer nuclei is also relevant for predicting response to checkpoint inhibitors. In a study that we presented at the World Lung Congress meeting last year, we showed that the spatial configuration feature was strongly predictive of response to nivolumab, one of the checkpoint inhibitors from Bristol Myers Squibb. And we also compared it with just TIL density alone and found that the spatial configuration, the spatial interplay between TILs and cancer nuclei was much more predictive of response for these checkpoint inhibitors compared to just TIL density alone, which was barely better than guessing. I want to come back very quickly to the heart example that I showed earlier. And so I gave you the example with the deep learning networks. Well, we came back, we revisited after having developed this spatial interplay feature with the immune cells. We took that idea and applied it to predict cardiac rejection grade. And what was interesting in work that was just published, presented at the USCAP meeting last month, we found that the spatial interplay or the spatial arrangement of the immune cells in cardiac pathology was strongly predictive of rejection grade. And so this is in about 410 heart transplant patients. We found that we could separate sort of low rejection grade from high rejection grade with an AUC of about 0.98. So again, there really is something to be said about having intuitive features that are also predictive. Number of other use cases, but I think I might be running out of time here. This is work we're doing in oral cavity squamous cell carcinoma patients. We're looking specifically at a low-risk group of patients, specifically patients identified by the AJCC staging criteria as being low risk. We found that features of nuclear morphology or histomorphometric features of nuclear arrangement were prognostic. So we actually identified within the AJCC-defined low-risk group a specific subset of patients that actually had high risk. And this is important because these patients would all have been treated with surgery alone. They wouldn't have received radiotherapy because they were defined by the AJCC criteria as being low risk. But what we found is when we looked within the low risk group alone, there was a distinct subset of patients who were truly high risk, and therefore this subset could actually benefit potentially from adjuvant radiotherapy. The other question is where to look, right? And so we've been focused on the tumor and finding patterns from the tumor in work that we presented a couple of years ago, published a couple of years ago. We actually found that there's a lot of information that's coming outside the tumor. In fact, if you look at tumor-adjacent benign regions, there are patterns that potentially might be more prognostic of biochemical recurrence in prostate cancer compared to the patterns that are coming from the tumor itself. So there's some value to really looking above and beyond just sort of the usual suspect places. And this is work we presented at the ASCO meeting where we again found that patterns of the stromal morphology in African American patients was strongly prognostic of biochemical recurrence, and that in the prostate cancer patients, African Americans versus Caucasian Americans, there were distinct differences in stromal morphology with respect to the disease. And so when we created a dedicated population-specific model of outcome in these prostate cancer patients, we found that we could much better predict recurrence in these patients compared to a model where we actually combined both the Caucasian Americans and the African Americans, suggesting that stromal morphology is important, but also considering population-specific differences might also be very, very critical as we develop these prognostic and predictive models. Andrew is here, and I just sort of want to do a quick shout out to HistoQC, which is work that Andrew actually presented at the Helsinki meeting and won the sort of Diagnostic Innovation Award. Please feel free to use this algorithm. It's freely available. Essentially provides quality control assessment, quantitative quality control assessment for pathology slides. And that's really, really critical, something for us to think about as we think about sort of deployment of digital pathology within the clinic. Just a final couple of slides that I'll end with. I know Darren's getting nervous there. But just a couple of things I want to throw out. We talked about pathology, but there's clearly a lot of work going on right now on radiographic images. This is some of our own work from breast cancer research a couple of years ago, where we showed that in MRI patients of breast cancer patients receiving neoadjuvant chemotherapy, we could actually predict which of these patients was going to have pathologic complete response versus patients who were not. And what was interesting was we found that the majority of the signal, the majority of the predictive signal didn't really come from the tumor itself. It actually came from outside the tumor. The question is why and what does this mean? Well, in a subsequent study that should be online next week in JAMA Network, we actually found that the patterns on MRI that came from outside the tumor were really the way they were because of the spatial arrangement of TILs from peritumoral biopsies obtained from that location. So essentially, the spatial arrangement of the TILs were what were driving the radiomic patterns or the texture patterns outside the tumor. And so this is something that I think is another role for digital pathology, where it can provide sort of a context, a morphologic basis to explain AI or radiomic features from radiographic imaging. This is work that we're going to be presenting at ASCO, where looking at CT scans of patients treated with checkpoint inhibitors, we found radiomic features, again, outside the nodule, are strongly predictive of response to checkpoint inhibitors. But what is interesting is that the reason, again, that these patterns are the way they are, that they're predictive of response, is because they're strongly associated with the spatial pattern of TILs on the biopsies from those locations. And so let me end with that. So hopefully what I've conveyed is that computational analytics with routine imaging can help address questions in precision medicine. I think one of the things that is worth considering is the fact that there's really a potential global impact, especially low and middle income countries. We're very, very happy, privileged to be working with Tata Cancer Center, where we're actually validating IBRIS for breast cancer patients with the group down in Mumbai. But also I think that there's, this is sort of my 2 cents. I really think ultimately to drive clinical adoption, particularly when it comes to prognosis and predictive medicine, that interpretation, intuition, interpretability, and establishing a morphologic molecular basis for your features is going to be very, very critical. Of course, it takes a village to do the work, and so I've been very, very privileged and fortunate to work with some outstanding postdocs, students, and faculty. A couple of them are in the room already. Of course, I just like to come and take credit for the work, but these guys are really the superstars who do all the heavy lifting. And of course, we've been very, very fortunate to have funding and backing from the NIH and the DoD. So with that, I will end. Thank you.
Fantastic. Thank you so much there. And I should highlight, this is a computer scientist who's presenting work at ASCO and publishing survival curves in clinical cancer research. What an amazing example of applied digital pathology. So we're a little bit tight for time, but I think we should have 1 or 2 questions from the audience. So I've got my capable assistant with a mobile microphone here. Get your questions ready. I'm going to start by asking Anant something which I thought was heartwarming, the idea that all these script kiddies coming along with deep learning actually have got something to learn from those of us who've done image analysis the hard way in the past. Can you tell us a bit more about that? But how does deep learning get enhanced by conventional AI?
So like I said, I mean, I don't mean to sort of ding deep learning. I just think that we need to think about sort of where there is bang for the buck, where there's real utility. I think there are a number of different examples where I think deep learning could be deployed, particularly in a triage setting. Again, I just point to this excellent NPR article that came out a couple of days ago that spoke to this, right? I mean, so you can think about deep learning where you may not necessarily need that intuitive basis for every problem that you tackle. But I think particularly cases where you're talking about triaging or just sort of rank ordering slides as one example, you know, AI or deep learning in particular could be very, very relevant.
Fantastic. We have time for 2 questions from the audience. First one here, this gentleman. Yes, thank you.
Hi, thank you. Great talk. So for those of us in the cancer...
Tell us who you are.
I'm Lawrence Young. I'm here at Warwick and run the cancer centre here. So I come at it from a sort of cancer oncology perspective. Right. And of course, you're absolutely right. We're all running like lemmings towards immune checkpoint inhibitors. And there's this great thing going on where everybody's staining everything for PD-L1. So what I wanted to ask you, with all the work that you've been doing, particularly looking at those clusters of cells and looking at morphology, what value is there in looking more precisely at specific biomarkers?
Brilliant question.
Tissue?
Brilliant
and how do you
question.
integrate that type of approach with immunohistochemistry into the type of algorithms you're developing?
Brilliant question. So I think that, you know, my mantra has been, you know, how much blood can we squeeze from the stone, right? So how much can you prize out of just the H&E slides alone before we start to layer on additional information? So that's at least been our mantra. I certainly didn't mean to disparage IHC. In fact, one of the next obvious logical steps for some of the work we're doing with the spatial arrangement of TILs is starting to look at the subtypes of the TILs. Like, so, you know, yes, we're finding this spatial configuration seems to be predictive response for checkpoint inhibitors, but, you know, are we really talking about CD4, CD8s? You know, what else can we prize out, can we glean from that? And I think we're just scratching the surface here. I mean, this is by no means a solved problem. I think we're working towards trying to come up with that biomarker. Right now, of course, you're aware, this PD-L1 is not the best biomarker in the world. Some buzz around TMB, but still evolving, and the landscape is still evolving. I think pathology and pathomics can play a strong role. I think H&E is still very, very valuable. And so we want to try to see how much we can get out of that before we start to bring in potentially other kinds of markers, such as from IHC.
Time for one more. The gentleman there.
Hello, hi. Thanks for a nice scintillating talk. I'm Matt Qureshi from Philips Research. I've got 2 questions, actually. One is, with what ImageNet taught us in computer vision and image processing was that, the more the data, the better the neural network. You say you found it different for medical images. And do you think if we have an equivalent ImageNet for medical images, would that resolve the problem? And second question, sorry, is actually, I worked a lot with handcrafted features as well. And there's a lot of work on aligning what handcrafted features are telling us and what the deep features are telling us. Do you think there's somewhere a connection there which we could?
Yeah. So so there's a lot there's a lot to unwind there with those 2 questions. But I'll take a sort of a quick sort of elevator pitch stab at trying to address those couple of questions. One is, I think that something that comes up repeatedly in the sort of neural network space is this issue, and I sort of touched on it very briefly, is, well, if it didn't work, we just throw more data at it. And I think that it's a little bit of a cop-out, if you will, to use an Americanism, because I think that without fundamentally understanding why the network is not working or breaking down, simply throwing more data at it suggests that you don't really want to figure out what the fundamental issue is. It's just like saying, my car is not starting up today, so rather than lifting the hood and trying to figure out exactly what the issue is, you can say, well, I'm just going to get another car. Or, so it seems to me that we need to try to get away from that and really try to figure out exactly what the fundamental issue is. And so great study from Mount Sinai, for instance, right? So I think they took the network trained by the Stanford group on the chest x-rays. It was 117,000 images or something like that, and it didn't work on the data from Mount Sinai, right? I mean, so that's a case in point where, it wasn't a small data set. It was over 100,000 images, but it didn't work. It didn't generalize, right? So I think that we just need to be wary, right? That just simply throwing more data at it may not really be addressing the fundamental issues. I do think that there is a lot of opportunity for synergizing, combining neural nets with handcrafted features. Saw something really great from Nasir's group in TMI, I think, earlier this week, where I think he's trying to do some of that, trying to sort of relate visual attention maps with sort of handcrafted features. I think that's very, very exciting. It's still evolving, and seems like a sort of a great opportunity. Thank you.